Hello and welcome again to another edition of the Osteopathic Lyceum podcast. Going to share some data from an outreach that the students did. So a clinical outreach on June 6th, the Canadian Massage Conference did a Free Friday event in Burlington, and we were there, so I presented a couple things, and the students were treating conference attendees. So the attendees would sign up, students would get proper consent. There's terms that I'm looking for some reason. They slipped my head. Proper consent signed. What I instructed them to do was assess, identify the three most restricted things, put them in a hierarchical order. So the most restricted thing, the second most restricted thing, the third most restricted thing. And then also ask what the primary complaint was. And then what they would do is they would treat the most restricted thing and see the impact that that had on the second and third most restricted things. So I had attempted to have the students record the data in a particular way so we could see how often the treatment of the most restricted thing would impact the second and third, or to what degree. Now, not all the students recorded it in the way that I asked, which meant that I couldn't extract anything from the chart on that level. But what did end up happening is I was able to look at the primary complaint and then the first, second, and third most restricted things that were reported and how often those things matched. So we were able to figure out how often the patient's primary complaint matched the most restricted area that the students found. So I want to note that if we look at a previous experiment, a student thesis experiment that we reported on, whereby there were predetermined areas that the participants were asked to report if they had pain or if they didn't have pain. So like right shoulder, right side of the back, left side of the back, right hip, left hip, stuff like that. It's about 50% of the time the areas that were reported as painful had mechanical dysfunction. There was breakdowns where there were areas where there was more likely, or there was more observed accurate reporting of pain that matched mechanical dysfunction, and other areas where there was less. So the net average was about 50%. Then in this case, we were more so looking at how often is the primary complaint the same as the primary restriction. And when we looked at that, it was about 45% of the time. So about 45% of the time, or sorry, 46, I guess we'll call it 46. 46% of the time, what the person complained the most about was the most restricted thing as observed by the person assessing them. Okay, so that seems very, very similar superficially if you don't recognize that the approach was different. So it sounds like we're confirming the previous observation, but the previous observation was report where you have pain in a blinded way. So there was a sheet, they reported where they had pain within restricted bounds, and then the assessment was made with no information being given specifically to the practitioner who was assessing. And then it was, I find mechanical restriction here, 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 with respect to the previously, or the same areas that the patients were asked to report on, or the subjects were asked to report on. So that's how that was observed and reported and done. But in this case, the practitioner knew what the most restricted thing was because they asked the patient for that information. Then they performed their assessment, and they didn't know that this is what I was going to look for. I was going to look for something else, but the manner in which they recorded their data, or really recorded their treatment approaches and outcomes, didn't match so that I would be able to extract the other data. So the numbers seem similar, but it's a different process. So it's not the same question, it's a different question. The question is, how often does the primary restriction identified match the primary complaint provided, right? That's a different question than how often do the areas of reported pain match the identification of any mechanical restriction. It's a slightly different question. Very similar in its general formulation, but it's a different question. So it's not actually confirmation of the previous result. Now we were able to then look, because we had a kind of a first most restricted thing, a second most restricted thing, a third most restricted thing. We were able to identify how often something that we found as a as a mechanical restriction, it matched the complaint provided and how often it didn't match. So when somebody provides a complaint based on this is painful, it was about 86% of the time. Is that right? Oh, 84% of the time. So 84.6% of the time, the complaint provided matched either the most restricted, the second most restricted, the third most restricted. I could probably go in and pick that data apart a little bit more. But then what that means is that it's about 15.4% of the time, the person where they report pain, we found no mechanical related restriction. Okay, so we've got some data here that sort of matches the previous experiment, sort of doesn't match the previous experiment. Keeping in mind that the formulation of the questions, how things were done, how data was collected is different. So it looks like it's a confirmation. It kind of sort of is, but it really isn't. We get a slightly different lay of outcomes or distribution of outcomes with respect to the question being asked. So what we do see superficially is that the thing that the practitioner will find that's the most restricted doesn't necessarily match what the person reports as their primary complaint or as a complaint. What we do see in this one is that we have a higher rate, seemingly, of where the person reports their pain to the practitioner. The practitioner seems to find some kind of mechanical restriction in the area of the pain report. So that will then mean that we should mildly adjust things that have been said before about how often one would consider the pain report as indicative of where they'll find mechanical restriction. There is still a difference between where the primary restriction is found and the primary complaint is made. So what that suggests is that there's still this thing that we have to figure out more. How often does the complaint match the physical finding? There's something there that has value to be investigated, because the claim that I'll make and that I have made is that the subjective report doesn't necessarily match the mechanical finding, such that it supports the quote attributed to Dr. Still, find it, fix it, leave it alone, nature will kindly take care of the rest. So we also then relate that to something we recently talked about, where the 3 different approaches to tender points really didn't produce any meaningful change in pain report pre and post in I think it was the upper trapezius, if I remember right, and that is from the International Journal of Osteopathic Medicine. So again, it's just the phenomenon happening over and over again where there is at least some difference between subjective report and physical finding, such that we have to acknowledge that our physical finding may relate to the subjective report and it may not. And there's going to be a rate at which that seems to shake out given large enough data sets, which we don't know yet, which we can continue to observe and experiment with. And at least in the 2 different ways we've done it, we get a slightly different distribution of results because the question's different, right? So harping on the fact that the data that I'm reporting now versus the data that we reported before from thesis experiment, there's at least some kind of difference. It seems like in the clinical scenario where the patient presents for some form of treatment and you ask them what their primary complaint is, it matches some mechanical restriction more often than it did in the thesis experiment, which was performed in a different way. And then if we track this down more over time, there will be some regular distribution which shakes out more often. It doesn't mean that in any patient encounter that you're going to find that average. It just kind of tells you what to expect and how often to expect that the subjective report of primary complaint is going to match a mechanical finding. So that one, the one that I'm reporting on now, is probably easier to do with a larger amount of people if you have a standardized approach to chart reporting. So if you have a primary complaint recorded and then you have a most restricted area, second most restricted area, third most restricted area, you can easily see if one of those matches to the primary complaint. Also, then what will happen is you can see how often it matches the secondary complaint and the third complaint. You can see how often that happens or how often it matches something. So we can figure that out easier over more time versus the experiment that was previously done where you have people fill out a kind of a bound report where it's like, do you have pain here, 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 right, left, right, left, right, left, and then you figure it out. So that's harder to do. It's harder to do it with one person. It's harder to do with more people over time, whereas a regular chart review, if you're recording it in the same way, it would allow you to figure out the rate at which the primary complaint matches the first most restricted area, the second most restricted area, the third most restricted area, or any restricted area that the practitioner is going to report that they observe. So lots of kind of rambling in a technical sense here. What's the big take home? The big take home is that we're in the process of adjusting our expectations and our understanding of how often subjective report matches mechanical finding. It's not the exact same range of results with the first experiment to the chart review report that we're doing. So we can call it experiment, we can call it chart review report, retrospective reporting, something like that. But we're in the process of adjusting how often the subjective complaint, especially the primary subjective complaint, is going to guide one to where they would expect to find at least some mechanical restriction. So want to talk about the fact that we've got to temper our claims as to how often the primary complaint will be solved mechanically, because there's a rate at which they co-occur. So mechanical restriction and primary complaint co-occur at some rate that we're not sure of yet, that we can figure out over time. And we want to do that across time so that we can then make a more confident claim as to how often somebody should expect that the primary subjective complaint will match some kind of mechanical restriction. So again, repetitive technical terminology, trying to come to and reiterate the main point as being there is going to be some rate at which the subjective report matches mechanical finding, and there's going to be some rate at which it doesn't. It doesn't change the behavior that is most ideal for an osteopathic manual practitioner. And the behavior that is the most ideal for an osteopathic manual practitioner is work on the restrictions that are found through movement assessment. And if they properly relate to subjective complaint, they will change together. If they do not relate properly to subjective complaint, the patient will move better, but the subjective complaint may not change or is less likely to change. So over time, we're trying to tease that out. The most appropriate way to behave, though, for the practitioner is on the mechanical restrictions observed through physical assessment, through movement-based assessment, because the subjective report is something internal to the patient that they can report to you, but that you can only identify through proxy, and those proxies aren't always that trustworthy, and we're finding that out more over time. So wanted to put that information out there so that you can see some of the process of getting there and also watch me reiterate the same thing over and over in a variety of ways. So thank you for listening this far. Hopefully you learned something, and we'll talk again soon.